Now we start our today lecture on iron deficiency anemia. Iron deficiency, number of cell reduced as well as concentration of the hemoglobin also reduced in RBC. Overview of today's discussion: what is iron deficiency anemia? What are the causes of iron deficiency? Factors influencing iron absorption. What are the sources of iron? What is the heme and non-heme iron? Iron distribution throughout the body. Iron absorption. Function of iron, internal iron cycle. Iron excretion, iron balance, iron values, clinical features of iron deficiency anemia, and laboratory diagnosis of iron deficiency anemia. What is iron deficiency anemia? Iron deficiency anemia is a common type of anemia, a condition in which blood lacks adequate healthy red blood cells. Number as well as hemoglobin concentration are reduced. Red blood cells carry oxygen to the body's tissues. As the name implies, iron deficiency anemia is due to insufficient iron supply to maturing erythroid cells. Clinical features in short: iron deficiency causes low production RBC as well as hemoglobin, difficulty to carry oxygen, reduction of energy production, fatigue, recurrent chronic infection, inability to heal. These are the gross findings of iron deficiency anemia. Causes of iron deficiency: main causes of iron deficiencies are excess demand, less intake, less absorption, excess loss, acute or chronic blood loss, defects in heme synthetic pathway, and impaired utilization of iron. Example: anemia of chronic disorders and sideroblastic anemia. Causes of iron deficiency anemia: iron deficiency or defect in utilization, defect in heme synthetic pathway. Iron deficiency due to excess demand, less intake, less absorption, excess loss, impaired utilization, impaired alpha beta globin chain formation. Defect in heme synthetic pathway: delta amino levulinate synthase deficiency or mutation, porphobilinogen synthase defective, porphobilinogen deaminase deficiency or defect, uroporphyrinogen 3 synthase defect or deficiency, uroporphyrinogen decarboxylase deficiency or defective, coporphyrinogen 3 oxidase defect or deficiency, protoporphyrinogen 3 oxidase deficiency, ferrochelatase or heme synthase defective or deficiency. I am showing the picture already, it showed on lecture on introduction of anemia. This is the cytoplasmic portion of heme synthesis. This is mitochondrial portion of the heme synthesis. These are the enzymes. These are the enzymes which needed to form protoporphyrinogen 3. Iron is incorporated to protoporphyrin 3 by help of heme synthase or ferrochelatase. Ultimately, it forms heme. Deficiency or defect in any of these enzymes may cause defective heme synthesis or reduced heme synthesis. Causes of iron deficiency: excess demand, less intake, less absorption, excess loss, impaired utilization, defect in heme synthetic pathway. Less intake, excess demand, growing children, reproductive female. Less intake, poverty, aberrant dietary habit, cooking abnormalities, anorexia, early weaning. বাচ্চার দুধ খাওয়ানো বন্ধ করে দেয় তাড়াতাড়ি। অথবা খাওয়াই না আর কি, ওষুধ দিয়ে দুধ বন্ধ করে ফেলে আর কি, মিল্ক। লেস অ্যাবজর্পশন, ইম্পেয়ার্ড অ্যাবজর্পশন, phosphate food, bread, cereals, milk, phytate, tannin in tea, alcohol and alkaline diets. Gastrectomy, gastroenterostomy, tropical screw, celiac disease. Excess loss, bleeding, acute and chronic bleeding, GIT bleeding, gum bleeding, hemoptysis, menstrual disturbances, অর্থাৎ dysfunctional uterine bleeding, hematuria. Impaired utilization, sideroblastic anemia, anemia of chronic disease, defect in heme synthetic pathway, inherited condition, heavy metals, poisoning, myelodysplasia. Excess loss due to GIT bleeding, peptic ulcer disease, esophageal varices, hiatus hernia, fissures and hemorrhoids, irritable bowel syndrome, malignant disease of the GIT, other acute or chronic ulcerative GIT diseases, parasitic diseases, chronic aspirin injection. Clear? Gum bleeding or internal hemorrhage, hemoptysis, menstrual disturbance or dysfunctional uterine bleeding, hematuria. Factors influencing iron absorption, facilitates iron absorption, inhibitors of iron uptake. Ascorbic acid, citric acid, acid diets, amino acid, sugar, meat. Phytate, polyphenols or tannins, proteins from soybeans, milk, eggs, calcium, alcohol and alkaline diets. Iron কোথা থেকে absorption হয়? Site of iron absorption, duodenum and upper part of the jejunum. Why? This area is acidic, but large intestine, rest part of the small intestine become alkaline. এই কারণে ওখানে source of iron, animal source, vegetable source, therapeutic source, cycling iron. Clear? Animal source, meats, liver, kidney, egg, yolk, hemoglobin, iron or heme iron. Vegetable source, green vegetables, fruits, cereals, non-hemoglobin iron, non-heme iron. Therapeutic source, hematinic therapy, oral and parenteral therapy. Cyclic iron comes from spleen where senescent RBCs are destroyed in splenic mononuclear phagocytic system, cells of mononuclear phagocytic systems. Hemoglobin iron, heme iron is in the form of ferrous, non-heme iron is ferric form. Heme and non-heme iron. The two forms of dietary iron are heme iron and non-heme iron. Heme iron is found in meat, poultry, seafood and fish. So, heme iron is the type of iron that comes from animal proteins in diet. Non-heme iron is found in plant-based foods like grains, beans, vegetables, fruits, nuts and seeds. Non-heme iron is also found in animal products such as eggs, milk products, etc. This is ferrous form, this is ferric form. Normal diet contain average 10 to 20 mg iron. Most are remain in the form of heme contained in animal sources, remainder being inorganic iron contained in vegetables. About 20% of heme iron and 1 to 2% of non-heme iron is absorbable. Diet contains sufficient iron to balance fixed daily loss, 1 to 2 mg loss, 1 to 2 mg gain. Most cyclic iron comes from the spleen where RBC are destroyed by splenic macrophages. The iron is recycled to the bone marrow via transferrin. The distribution of the iron throughout the body, bone marrow 300 mg, circulating RBC 1800 mg, splenic macrophages 600 mg, muscle 300 mg, liver 1000 mg, plasma transferrin 4 mg. erythrocytes, plasma, body stores mainly in the liver, myoglobin, respiratory enzyme 300, liver 1000, plasma 4 milligram, absorption 1 to 2 milligram daily loss 1 to 2 milligram. Used by bone marrow 20 milligram for RBC production. Senescent RBC is destroyed in the RE system in the spleen. RBC destruction 20 milligram daily iron comes out from spleen to circulation. This is plasma transferrin 4 milligram, muscle contain 300 milligram, bone marrow 300, circulating erythrocytes 1800, reticular endothelial system 600 milligram, sloughed mucosal cells, discommotion, menstrual bleeding and other bleeding loss, average loss 1 to 2 milligram per day. Daily dietary iron, duodenum average 1 to 2 milligram per day in iron absorbed from the duodenum. Dietary iron, iron loss. Dietary iron, absorption of the iron from the duodenum, average iron absorption per day 1 to 2 milligram. Daily loss, average daily loss 1 to 2 milligram per day. Thus, this way iron is balanced all over time. Iron absorption, sites of iron absorption, duodenum and proximal jejunum. Factors modulating iron absorption, size of the iron stores, rate of erythropoiesis. Size of the iron stores. Iron stores যদি কমে যায় absorption বেশি হবে, iron store normal হলে absorption normal হবে, iron store যদি বেশি হয়ে যায় তাহলে absorption কমে যাবে। Rate of erythropoiesis synthesis. Erythropoiesis যত বেশি synthesis হবে, iron তত বেশি প্রয়োজন হবে, iron তত বেশি absorption হবে। Regulation of iron absorption, amount of iron storage in the body, overall rate of erythropoiesis in response to hypoxia and inflammation. This is a pictures of RBC, nucleated RBC. These are the transferrin receptor, dipheric transferrin. Dipheric means ferrous form, ferrous iron. Endocytosis, iron as well as the receptor. Then endosome acidic form, enzyme is activated in acid state, this iron is released and receptor is come to the cell membrane of the RBC. Transferrin receptor, this one is transferrin receptor, dipheric iron or ferrous iron, endocytosis, this endocytic vesicle or endosome then release iron and receptor of dipheric transferrin come to the cell membrane. Iron then used by mitochondria to form heme and excess iron is stored as ferritin in liver and as well as in the plasma and other organs. Then ribosome form alpha and beta globin chain. This heme and alpha and beta globin chain then mix to form combination of heme and globin chain form hemoglobin. Thank you very much.